Thank you everyone so much for joining today. I'm going to get us started and we're going to try to stay on time so we can fit right into your lunch hour. Happy holiday week to everyone. So this is our November webinar for Dementia Care Aware, and it's a really exciting one. We're going to be talking about updates for the program and what we're saying, new horizons. As you'll see here, we have West Health joining us. So I'm really excited about what we get to present to you today. So this is just a disclosure slide. You will see it in the slides that we post if you wish, but we are using PACE as our CME company. And today we have no disclosures. I'm Dr. Anna Chodos. I'll introduce myself and again in a minute. And we all are also very privileged to be joined by Dr. Zia Agha today as well from West Health. Just really briefly the main reason I'm leaving the slides still up is because we have to acknowledge the incredible support, establishment, inspiration, and foundation of the program from the Department of Healthcare Services from 2022 to 2024, end of September, a couple months ago now. And just want to point out that this particular webinar does not represent their official views or policies. So quick logistics, I sometimes take the first few minutes to just go through some of these warm-up items so that more people can filter in as well. But wanted to make sure everybody knows that we'll still keep the Q&A and the active. So if you have any questions, please put them there. We'll be monitoring it throughout, and I'll try to get to any questions you might have as I'm talking and as I'm going over the material. So appreciate that. We will also hopefully have some time at the end. Everything is always posted on our website in the appropriate section in the education section at dementiacareaware.org at the end of the webinar. So the video will be up and the slides will be up in about 24 hours. And then right at the end, sort of at the end of the hour, you'll get information about how to claim CE and CME, which we really want you to take advantage of. So I hope you get that information and do so. Our brief agenda today, I'm going to go over introductions. Again, I'll go over who I am and who our other speaker is. We're going to briefly review what we accomplished in the last 2 years, and that's so we can kind of really feel the amazing foundation that we have to build on next steps. We're really excited to then talk about our new partnership with West Health and the interests and the work that West Health is doing in the dementia space. Then we're going to this is the educational part, so I just want to bookend that for you in case you've already seen some of this material. But what we're going to go over again is why early detection is so important and how we promote that with the cognitive health assessment, and then how we're really going to start turning towards next steps in dementia assessment. So we'll go over what that is, what you do after a positive cognitive health assessment. And again, that's sort of our dementia education section of the talk. And then just a little reminder at the end that we're always looking to work with folks, and particularly knowing what you'll know by the end of this webinar, we really want to invite you to partner with us if that's of interest. These are our learning objectives, which again, you can review and will be relevant to the CME once the session is over. So great, now I get to go to the introductions and to today's speakers. I look a little bit like the photo on the left here. I'm Anna Chodos. I'm a geriatrician and internist at UCSF, but most especially relevant to today, I'm the executive director of Dementia Care Aware and very proud to be with you today. And then I have Dr. Zia Agha here as well, who's the Chief Medical Officer of West Health, and we'll be talking and representing the work that they're doing. And so I just want to say welcome. Welcome, Zia.
Excited to join you. Well, thank you so much for first inviting me to join this presentation. But even beyond that, we're so honored to be partnering with UCSF and Anna's team, and then DHCS, and the tremendous work that has happened in this space through Dementia Care Aware. Just by way of background, I am, like Anna, an internal medicine doc. I've been with West Health for the last 10 years. So both have sort of some personal experiences of dealing with this special population, and then obviously through the lens of West Health. West Health, for those of you who don't know, is a nonprofit organization. We're based out of San Diego, and we conduct both medical research in terms of applied research and also policy related work out of our office in DC. When we think about our work, we really try to focus on the needs of older adults and healthcare cost. And when we come through those two areas, dementia and Alzheimer's and related diseases are a key area for investment for us. But I want us to sort of not dive too deep into this, and I think some of this may be familiar, but it's a good way to frame the discussion around Dementia Care Aware. If you look at the journey that most of our patients and our loved ones go through in terms of this diagnosis, uh, there's some activity that can be done in sort of what we call primary prevention activities. We're not going to focus on that. But when it comes to patients developing symptoms, whether they're very early on or slightly more advanced, often these symptoms are going to be noted by family and caregivers, and then the primary care teams that take care of these patients on a regular basis. So that's where the initial screening and diagnosis opportunities are, and that's why it's so exciting what Dementia Care Aware is doing. But beyond that, we see a role of primary care stretching in coordinating the care of these patients across the continuum, across the diagnosis, treatment, and monitoring and follow-up. It's clear that the needs of these patients are diverse, yet the access issues that we face due to the shortage of neurologists or any of the specialists like neuropsychiatrists is real. And so the work that we are all doing together with Anna and team is how do we leverage Dementia Care Aware's framework and at a national level engage with frontline and primary care teams to play a much more significant role in screening, treatment, and monitoring. I think if you think about the treatment and the treatment plan, so the so-called brain health plan, it's important to think about the non-pharmacological options like the hearing and vision and those types of things, or mobility. Of course, DMTs are a big area now that is growing, and then symptom relief, whether it is symptom relief of some of the psychiatric symptoms or other things, and the co-traveling diagnoses like depression. And then, of course, coordinating that care and providing monitoring and follow-up. So we see really a role for primary care across the continuum in this population. Yet we understand that there are lots of barriers for this to become reality today. Yeah, I think there are issues related to both referral rates and low screening rates. There is stigma from the patient and caregiver side in terms of addressing these needs. There's diagnostic complexity. And then on the treatment side, while the DMTs are promising, there's still lack of efficacy for most of these treatments. And our primary care providers often don't have the education and the support needed to provide those types of treatments. And only a select group of neurologists are using these drugs today. And then in terms of monitoring and long-term follow-up, you can obviously get into the caregiver burden and the limited provision of services and support for them, things like respite care, but also the long-term care community like nursing homes. Again, across the continuum, there is low level of care coordination, which can often lead to duplicated efforts and poor outcomes. And I think that's where primary care, which is the patient's medical home, can play a really significant role. So as we thought about partnering in Dementia Care, where we sort of came up with West Health's framework of where the who, what, and the how, and this is a busy slide, but really our focus is going to be on focusing on mild cognitive impairment, sort of the early intervention of this disease, and working with teams to help both identify and manage those patients. We see that there's a significant opportunity to improve care delivery through coordinating the care, both through primary care vectors, but also through caregivers and family systems and public health. And then ultimately, we believe that we have to support these primary care programs by working not just with them, but also looking at policy interventions. There are policy movements happening already. Some of you are familiar with them, but there's a lot of excitement in Washington, D.C. and at the state level on providing that level of integrated care. And as a policy team, we are also looking into those opportunities. And so again, I started by saying we're so proud to be working with Dementia Care Aware team, and sort of as I think about some of the goals that we have and some of the areas that we want to travel into, we definitely want to accelerate the opportunities to improve patient care by engaging with more providers. So please go to the DCA 2.0 website, contact West Health. We want to empower and enable our primary care partners because they are going to play a huge role. I think there are opportunities to invest with novel partnerships, partnerships with guide programs, the American Hospital Association that we are exploring together with Anna and team. And then most importantly, how do we change the narrative around dementia treatment to go from where it's a diagnosis that we cannot do anything about to a diagnosis that leads to a brain health plan for every patient. With that, I'm going to end and pass the baton over to Anna. Anna, thank you so much again for this invitation and for the collaboration.
Well, thank you. And it's so fun to think about, the bigger picture and how DCA fits in and how we can play a small role in what is a tremendously large effort, multi-sector effort, across all of these different aspects of care that were so nicely mapped out. So thank you so much. Yeah, I will bring us back to, I think what's so great about the way you presented that is the way, even looking at this huge sort of enormous context of dementia care, all of the factors that, all the places you could work and do great. You could do great things. You could do, there's so much work to be done to improve care, people getting access to treatment, to monitoring and ongoing care, caregiver burden, as you mentioned, long-term care, and we all care about those things. But one of the really exciting things about Dementia Care Aware for me is the emphasis on, how we get this journey started as early as possible for people living with dementia and their caregivers, if they have caregivers. So we're going to go back to sort of the Dementia Care Aware mission and think about early detection and why we start there. And then I think it's clear why we partner with West Health in terms of really emphasizing the earliest intervention possible is the way to preserve brain health as much as possible. So as many of you know, a lot of our drive was in a lot of that diagram, but something we emphasize in our training, and many of you may have seen this before, and these are the updated 2024 figures, is really that this is a highly prevalent condition, with over 10% of the population of older adults in the US living with dementia, and as only Alzheimer's disease is only one cause, but at least that many have dementia, right? And we know 720,000 of those folks live in California, which has been, of course, our primary focus. And we know as people get older, the burden is higher. So it's very age related, and more people as they get older, higher proportion of those folks are living with dementia. The other reason we care about early detection or screening, and I use those terms interchangeably for lots of reasons during this presentation, but it's to address disparities. So we know that the burden of Alzheimer's disease and related dementias and the lack of quality care is sort of a dual whammy for people from minoritized backgrounds. So the data show that people who are non-white tend to have a higher burden of dementia. So folks who identify as Black have roughly twice the lifetime risk of dementia, and those who identify as Latino or Hispanic have 1.5 times the risk. This was really interesting in the last California Alzheimer's Facts and Figure, showing that we're getting better information about different groups, different Asian American and Asian descended groups, and depending on background, the risk may be different. But at the end of the day, we know that there's also data that show that our Asian American residents in California don't get the same level of diagnostic workup and care. So I know this is highly motivating to me. And one thing that really gives me hope about working with so many people now over the last 2 years in terms of using a screening approach or a global, assessment approach for everybody, especially if we're doing that in a linguistically and culturally appropriate way, that hopefully we can detect more dementia earlier and help to reduce some of the lifetime burden of this condition for people living with it. And then I'll just shout out to a video that we made talking to primary care in across the state. And this is Dr. Heather Schickadance, one of our great and incredible champions in LA County, chair of family medicine at Harborview, who, if you go to our website, it's the first thing that pops up. And we really tried to help, just one additional thing out there to help build the case for early detection. Again, screening, early detection are really similar at this point in the clinical detection of dementia and the DCA approach. So encourage you to watch our video and understand our passion for this issue. So I do want to take a moment to just talk about our accomplishments over the last 2 years, mostly so that you understand what we're building upon as we build the next 2 years of Dementia Care Aware. So it goes without saying that with the support of DHCS and an incredible network of people across the state, we just all came together to get as much done as possible. So I just want to make sure to show, as small as they are, the faces of some of the incredible people that worked with us the last 2 years to get all the work done and all the incredible things done that you're about to hear about. These are all the institutions and organizations that also were part of our partnership and really deserve all the credit. So our UC collaborators, and then you see many Alzheimer's and related organizations as well across the state. Southern and Alzheimer's Association represented the northern part of the state, as well as did a lot of our outreach. So we just had incredible colleagues, and that's another wonderful part of working in this area with dementia. We created the cognitive health assessment. I'm going to review it because I can't ever get through a webinar without reviewing our cognitive health assessment. But a really important piece of this was, one, thinking about the early detection piece, two, really emphasizing cognition, function, and social support throughout the program, and that included in the screening moment. So not just cognition, but really acknowledging the breadth of the syndrome and also the breadth of what we need to do as clinicians to care for people when they have this condition. And then this is brain health. We really emphasize brain health from moment one because we want people to live the best lives they can with what they have. Okay, so we really focus on education and training, and this is my way of reminding you that we have our basics course, which is how to do the cognitive health assessment. We were doing that live many times a month over the last 2 years, and so proud to, I hope many of you were part of one of those sessions, but we also have other courses for you to consider and take a look at, and these are all online. So how to do it as a team, how to do it over telehealth, how to adapt it if people have sensory disabilities or speak other languages or have other needs that might cause you to want to think, how am I going to adapt these tools to this patient? What to do after a positive screen, and that's actually going to be the second part of this webinar. I'm going to go over that. How to start to approach advanced care planning, work with care partners and caregivers. And then the dementia mini course is really, once somebody is diagnosed, how do I care for that person? So it's almost all there if you need to know how to detect, assess, and address dementia. We did webinars like this one with wonderful attendance. Very proud of that. And then a podcast after each webinar. And so a lot of the material is available in a lot of different ways. So hope that it's still of good use to everybody. As of the end of early October, we had trained 5,659 people. So that is an incredible accomplishment, I think, for, again, a short run so far. Many, the majority compared to other groups were clinical providers. So that makes me feel really great that I hope we're truly building competency and capacity for dementia assessments and screening in primary care. And then we've reached providers in almost every county. We have a whole support network as well. So as you know, training and education has been a dogged and energetic focus of our program, but we also wanted to build tools so that clinicians in real live clinical practice on any given day could hopefully get support from us around dementia management. So we still have our warm line, and really want to offer that to you, as well as you can always contact us with clinical management questions through DCA at ucsf.edu. And then throughout the last phase of the program, we were really connecting people as much as possible to these incredible really world-class resources around implementation support and coaching in clinical practice. And that was the UCLA's Alzheimer's and Dementia Care Program and the Alzheimer's Association's Health Systems Implementation Team. We also created an implementation guide, which I'll shout out again towards the end. But these were all things that we were able to provide the last couple of years. Just want to plug that these programs are still very much operational, and we will always do our best to connect them to clinics that are a good fit if that's ever useful. So what did all that training lead to? Well, as of most recently, we've been able to collect information, de-identified, of course, that 2,214 cognitive health assessments have been done. We obviously don't know about all of them and in all the settings, but working with our pilot locations where we really had our champions and we're very tightly connected, we were able to get at least these many done. And again, these are almost entirely in family health clinics and safety net settings, so federally qualified health center settings. So really, really proud of that. And we're serving who we want to serve, which is Medi-Cal and Medi-Cal Medi-Medi older adults, people who rely on those benefits. So that was really important to us because that has been the thrust of our program. We want everybody, believe me, we want everybody who's older to have an adequate assessment and access to a screening, but very proud to have been able to serve this population. And you'll see in our implementation guide that we have clinical implementation examples from these settings. So hopefully that resonates with your care practice. Okay, so couldn't help myself, just a little bit of reveling in the amazing work that we've done, really taking stock of the wonderful foundation that we've built. So what are we doing next? And we were really fortunate to hear from Zia about the work that West Health is doing and how we're going to be partnering with them to really continue to build out care pathways that start with early detection and encourage brain health. So really, the way I think about Dementia Care Aware, and I have to say we are 2.0, but our website's the same in terms of address, at least. So we will be revamping it and continuing to improve the website, but we just sort of fondly refer to ourselves as Dementia Care Aware 2.0. And really, why are we still here? We're here to ensure that all older adults and their caregivers receive the earliest possible dementia diagnosis and excellent care through capacity building and practice transformation in primary care. So I just want to highlight a couple of things. I keep saying Dementia 2.0 is really our opportunity to finish the sentence that we started around early detection. We really wanted to promote screening and early detection because we know there's so much we can do to support brain health as early as possible. And that patients or people living with dementia and caregivers really, really appreciate knowing as soon as possible, as early as possible. But the second part of the sentence that we get to finish with this next phase is really the part after the earliest possible dementia diagnosis. So we get to support people to do excellent care by more capacity building and supporting practice transformation in primary care. And again, our focus is really primary care. This is where a lot of the care is happening. It's where my heart lies. So this is really, really important that primary care feels supported, has the tools they need, has the capacity that they need to manage this condition. So we are going to keep doing a lot of the same things because we think it's really valuable. So we're going to keep our live trainings going, meaning you could sign up for a cognitive health assessment training. And we're hoping to offer some other aspects of training too, and we've done this in other settings already, meaning, other training on next steps or medical legal needs of older adults, things like that. At the current moment, one of the reasons to continue the cognitive health assessment training is also that for Medi-Cal, you still have to be registered as having taken our training in order to be able to use the billing code associated with the screening for Medi-Cal. Just a heads up, that may be changing. So then we will just still be a wonderful resource, but maybe not as required. But we are going to continue the training as much as we possibly can, even though we're having to scale back a little bit. We obviously still have our online modules, and our main goal before the end of this year is to start to improve those and update those. So I will just make a plug. This is a wonderful opportunity for your feedback. One thing we hope to do, for example, is make some of them a little shorter. And then we are really, really happy again to do additional live trainings. So if you have a opportunity that you think is a really good one, or a regular standing meeting at your clinic, and this would be a useful training, please just contact us. And I put here, and I just want to shout out one wonderful partnership we get to continue is with the Alzheimer's Association outreach team. This is really led by Amanda Valenzuela, who's just incredible, and an incredible advocate for this work and a great connector. So I've put her email here if you want to reach out for live training. You can always just reach out to the general dca@ucsf.edu email as well. But we really want to train if live and whenever possible, if that could be useful to you. Now I'm going to go into a little bit more of the didactic session on the dementia education in part two. We always want to take an opportunity to support you with that. So please just take note. I'm going to go over the cognitive health assessment briefly and our next steps module and tools briefly as well. Because again, I'm really, really thrilled for this additional time and opportunity so that we can finish that sentence, so that we can all feel as clinicians and healthcare teams that we're ready to help patients figure out what's going on, what's causing their symptoms when they do have a positive cognitive health assessment. So we're going to still promote the cognitive health assessment as an easy, quick, early detection tool. So one thing, like for example, where I work, we are setting up protocols to screen everyone older than age 65 annually who don't already have a pre-existing diagnosis of dementia with our cognitive health assessment. And that's really the target group. The components of the cognitive health assessment are to take a brief history, use validated screening tools to assess cognition and function, and then document care partner information briefly. When we look at the information we have and whether or not the screen is positive or negative, we're using parts 1 and 2. As you can imagine, whether there's a care partner is not determinative if there's a positive cognitive screen. But we put this here because, again, we really want to recognize and continually emphasize the importance of our care partners and caregivers in the lives of folks living with dementia. And even more importantly, if they happen to not have that support, that's a place where we can really start to intervene and support them. I always like to go over our tools for screening because the reminder here is that we have given folks options for using validated tools for cognition and function. So we want to do a quick screen on cognition and a quick screen on function because those are the two criteria in making a diagnosis for dementia. We need to know if they've had a cognitive decline and a functional decline. And there's something we can do about both of those things. And there are validated tools for both of those things. And there are short assessments for both of those things. We also point out that you can actually get a lot of this information from an observer or an informant that comes with the patient, or you may be able to talk to that person over the phone at another time. So you can actually get a cognitive assessment and a functional assessment on your patient, on the person you're assessing via the care partner. So that's hopefully a useful tool and a useful approach to spread out the assessment in terms of if you're doing other things with the patient who probably has a lot else going on as well. And it's another way to involve the care partner. And we often like to get collateral anyway. And then very, very importantly, as many of you have seen in our core trainings, the other wonderful thing about the cognitive health assessment is if it's positive, we really emphasize starting a brain health plan. So at the very earliest symptoms of any sort of decline, there's a bunch of things that you want to do that will really heighten the health and wellness of that person's brain, among other things. So we always want to assess and address, additional medical and psychiatric causes of any symptoms or functional decline. And that might even come later after a screen. But really, there's a few quick things we can start to check off as part of our care plan. And I know for one, I really enjoy being able to talk to a patient and say, hey, I've done this assessment. And there's we've noticed these things. We did this test. Let me show you the results. There's a little, you had a little trouble with this section, so we should follow that up, for example, or it looks like you're needing more and more help with some of your activities like cooking and shopping. We should follow that up and talk more about that at a future appointment. But right now there's things we could do to really support your overall health and your brain health. So let's get some of that started. The big ones are sensory impairment, addressing that as early as possible, hearing and vision, reviewing medications for anything that's potentially impairing cognition. And there's tools for that, like the anticholinergic burden calculators, encouraging social and physical activity, and managing blood pressure, diabetes, and LDL. LDL being a new risk factor that was noted in the recent Lancet publication on the risk factors, modifiable risk factors for dementia. The other wonderful thing is this is like absolutely what primary care excels at is assessing and addressing these issues right here and helping to motivate patients to be more socially and physically active. And we all know these can be hard things to do and things we will work on over time. But to emphasize these and put them in the box of this is really good for your brain, as well as your heart, as well as your emotional health, I think can be really powerful. And personally, on my end, also feels really active. Like it's something I'm really doing for the person, even though I don't quite know yet why their screen was positive. Okay, so now I'm going to talk a little bit about some of the things we go over in the next steps module in our on our learning management system platform, which you log into via our website. And, it's just one of those things with 2 years, really trying to get the word out about the cognitive health assessment, this wonderful new benefit with DHCS and our Medi-Cal patients, could never really get, I think, enough time to really say, well, what do we do next? And I know as a clinician, it's really, really important to know what to do next. And a brain health plan is great, and it's really important. Maybe even might cure some folks, but we do want to know how to really follow up on the other pieces of assessment and management. So I actually, there's a snapshot from my course. I did finish it, but wanted to show that you can go back and forth during the assessment. And it just kind of marches through, okay, someone's had a positive screen. How would I really dig in on what to do next and how to evaluate that? So really, how do I get to a diagnosis? There's a course handout, so that's for easy reference. And I just want to point out, we really are trying to make the tools as usable as possible and really appreciate your feedback at any point if there's something we could do. This is the framework. I think I'm really trying to keep it simple today because the workup can honestly be pretty overwhelming. So if you've done the CHA and you've taken all that training, we really recommend emphasizing this as a positive screen. It doesn't mean anything's going on. We really need to do another assessment. So let's have some follow-up visits to go over that, but we can start a brain health plan today. And then we work on really evaluating the patient and doing the next steps, getting to a point of feeling comfortable disclosing a diagnosis, and then ongoing care. So really throughout, and that's hopefully what the sort of blue line indicates, that throughout we're really connecting to resources, addressing the needs of the person living with the symptoms or dementia and the care partner. But once they have a diagnosis, it's still a really, really active issue. People have a lot of symptoms, they have a lot of needs, and those are ever changing. So keeping it on the list of things to check in about and feeling like we know what to do next as we're making an action plan. And there's just a couple of things here. It's a little, like I said, this framework is abbreviated, but hopefully help keeps in mind sort of the big pieces. So I'll walk through some of them really briefly. And I think some of the big things to keep in mind are right after somebody screens positive, we just want to start addressing their brain health plan. Also really knowing that we can assess the cognitive and functional decline, kind of piece by piece over time. So it doesn't have to be all in one 1 hour visit. It certainly could be, but if we need to, we can break it up. But one message to send to people we're caring for is this is important. I am going to follow up on this. We're going to work on this, and it may not be urgent, but I do want to follow up on this and support you through this. So then what would we do? So now we're at the next visit or at the follow-up visit. How are we going to get to a diagnosis? And the big pieces that you see on the left are getting a deeper history of what's really going on, starting to do the work of ruling out potential contributors to the symptoms. May not be true causes or curative things that we can do, but it may be that they're really contributing to some of the symptoms. And looking for any major red flags that would say maybe this person needs a more urgent or more specialist evaluation if that's available. So for the history, again, the way I think about it is in that same framework of cognition, function, support system, cognition, function, support system. So what is the history of the cognitive symptoms? Can I get a little information about more than just memory or more than just language or whatever their presenting symptom was, or their main symptom seems to be? And the main key things that I always try to take away is, do I have a sense of trajectory? Are these symptoms getting worse in any way? And over what time period? And then how serious are they in general? So if someone's saying, oh, I'm having trouble with memory, it's like every time I walk into a room, I forget what I'm doing. That's a really common one. I had someone report that yesterday. But they give themselves a minute and they're able to think about what they were going to do. They remember and they get going. They sort of get back on track. By the way, that may not even really be a memory symptom, but it sort of feels like a memory symptom. Versus someone who's telling me, it was strange. Lately, people tell me I just like don't do things, and I didn't even realize I was supposed to do them. I had no memory I was supposed to do them. Like my daughter got really frustrated that I said I would do this thing, and I never did, and I couldn't even remember we had that conversation. One of those feels a little more severe in terms of level of symptom than the other, meaning they can't really compensate. They may not have awareness that they're even having that symptom, or it's really more disruptive. So those are the kind of ballpark qualities I'm trying to get about the symptom. Is it slowly getting worse? And how severe is it? Is it getting more severe? And then the function, very similar, like how do you do these things? Is that changing? How is that changing? Is that changing? And then why is that changing? Does it seem like it's really related to a physical decline versus a cognitive decline? And this is where we really rely on our clinical skills to try to understand, if we can, and sometimes we can't, if it's really more likely to be a cognitive related functional decline, which is, of course, kind of the signal we're looking for. And then collateral, whenever possible, and many times it is not, but whenever it is, trying to get some report from an outside observer, someone who knows that person somewhat well, about both the cognitive and the functional symptoms. That really helps us feel like we're triangulating the issue and understanding how that person's really doing. We do a brief physical exam, often looking for some neurological signs. One of the big ones is Parkinsonism or rigidity, cogwheeling, some motor changes, because that can be a sign of some of the non-Alzheimer's causes of dementia or vascular Parkinsonism. And then if available, sometimes we do deeper cognitive testing. Many people at this point will do a test in the clinic, like a MoCA, if that's appropriate, or a RUDAS, if that's appropriate. So there's different longer tools that people use. And if we happen to have access, sometimes we'll get a neuropsych. It's not really depends on the situation. It's not necessarily a requirement that the person have an in-depth, very long neuropsych test. And I just want to put the plug in there. It really has to do with the person's situation, what resources are available, of course, and then what is that person's background? Would this really help? So somebody with autism or a serious mental illness or a severe depression might really help to get a neuropsych, because perhaps we can tease those things out a little more. Or someone, usually if they're mild, it tends to be more helpful than if somebody's really impaired. Then clinically it can be really obvious. We don't need the neuropsych to support that, or we don't need the MoCA to support that. And then, of course, and this is where most medical doctors really excel, is ruling out the other medical conditions. So looking for reversible causes like B12 deficiency, thyroid problems, usually hypothyroid, neurosyphilis, or untreated, undetected HIV infection, which is totally possible in older adults. It's one of the populations least detected for HIV, but of course, you would consider risk factors for these things for the RPR and HIV testing. Brain imaging usually obtained to look, just make sure there's nothing we're missing that isn't dementia. So things like tumors or big strokes that were never diagnosed that might change other types of management. And then comorbid conditions that really impact people's cognitive abilities. The big ones are sleep apnea, substance use disorders, and serious mental health conditions, or, at the time, poorly controlled mental health conditions. I would say these are unlikely to explain a years-long cognitive and functional decline that's slowly, gradually getting worse, but can definitely cloud the picture and really worth treating and supporting people through if we can. And people, often feel a lot better if they're getting treated for these things. So we always screen for these things. Again, this is not a totally exhaustive list of things that we do in the next steps evaluation, but it's really highlighting the big pieces here with these slides. And then the last thing I'll say is it is always nice to keep in mind some red flags that really may suggest we should refer to a specialist if we can, sooner rather than later. So if people are, a lot of times people will say they haven't had symptoms very long, like 6 months, but when you really dig in, it's been a couple of years and it's just now getting kind of most noticeable in the last 6 months. But if people are really noticeably declining rapidly, and that means within the last 12 months, we should get them to a more urgent neurology eval usually to look for less common causes of dementia, like Creutzfeldt-Jakob disease and things like that. Comorbidities that do elevate the risk that something unusual is going on in the skull. So things like metastases to the brain or unusual infections if the person has poorly controlled HIV infection. So these are things that might really want to move us at the very least to head imaging. Same thing with focal neurological findings that we can't really explain. What we would say severe behavior changes. So this might be an atypical form of dementia. So something like frontal temporal dementia might really present, first of all, more at a younger, earlier age, and then with really unusual behavioral changes that don't feel sort of typical for Alzheimer's disease or sort of like typical dementia. Parkinsonism, if someone's on anticoagulation or has a history of a fall, these are all, I would say, also just indications for also sort of shorthand for it's really more valuable to get a brain scan. Sorry. And then the other thing is, of course, younger age at onset. So we consider young age at onset sort of under 65, when, of course, we know with the long tail of preclinical disease for many of the causes of dementia, that people, of course, may have some subtle symptoms early in life. But again, that does, like early, middle, in middle age. And so that does really encourage us to do a deeper workup sooner. Okay. And then finally, if we feel like we've collected all our information and we have a clear sense that we understand this person has had a progressive cognitive and functional decline, and we're ready to deliver a diagnosis, other things to do in that moment are really to think about what stage they're at, to communicate that. And there's sort of some, if function sort of tracks with stage, and there are tools or scales we can use as well. And then to really plan and think about disclosure. In some of the other DCA materials, you'll see we do really encourage disclosure, or what I would just say open conversation about what you're learning, what you're detecting, how you're thinking about their clinical symptoms and their condition throughout. And that's because that gives us an opportunity to talk about brain health and improving those symptoms that way. And it gives us a chance to prepare for what might be a bigger conversation if we've detected and we feel like they meet the clinical criteria for dementia. So I just put some key points here of really thinking about it, if possible, planning enough time to go through it. I always just walk people through what I've learned through the process of talking to them about symptoms, what I've learned from the diagnostics, and why I think they meet criteria for dementia, and then how I'm going to support them and how I want to see them again, how I want to follow up and focus on brain health and life planning, advanced care planning from there on out. And part of that is, and it's sort of buried in here, but in the second point, we just hear time and time again that people living with dementia and their caregivers report getting diagnosed and then adios from their clinical team, or getting a 1-year follow-up. And that doesn't feel great, and they feel somewhat abandoned. So that's something I think we can also easily address by keeping it on the problem list, really keeping it as something we want to actively support. And there we go. Once somebody has a diagnosis, that care plan needs to be really active. And I realize a really brief in our diagram there of optimizing function and caregiver support, but this is where we spend years. We spend years and years and years continually working with caregivers, getting new caregivers if the person doesn't have one, or working with city services or other agencies to support them, working on advanced care planning as soon as possible so the person can participate, working on safety planning, and then optimizing function and cognition as much as possible, and keeping symptom assessment as a key piece of the work we do. Now, you may be thinking, where do the disease modifying therapies that are coming out and the new diagnostics fit into all this? And I think that's a question and a piece of this that we're going to have to start talking about in more specifics, more and more, as these things become more widely used out there in the ecosystem of care, if people really do get more access. And again, a big feature for us would be who's getting access and how and why, and can we work on making that as equitable as possible. A plug that we have a wonderful resources page for those pieces of the action plan and the care plan, safety, community resources, caregiving resources. And I just highlight one because it's so good. The best programs for caregiving, Alzheimer's Association, Family Caregiver Alliance. We have links to all of these incredible resources in California and in the nation. We have as well clinical implementation resources. We have an amazing implementation guide that's both interactive and in PDF format. And I really want to put in a plug for this because this is where we hope to go next, which is really helping to embed early detection and a care pathway in more primary care settings, and to support practices to do that. So we know that we're entering a world, it's not just us and our sort of fanaticism for early detection and screening. We are moving into a world to focus on early detection. And this kind of comes full circle with Zia's presentation on the incredible amount of, incredible number of pieces that fall into place for a real care pathway related to dementia. But we are focused on early detection because we know that, one, there's lots and lots of movement in that direction, not just Medi-Cal of all things, having the foresight to put out there a screening benefit for Medi-Cal patients, and Medicare, has had the annual wellness visit and similar benefits forever. So we know that's already there in place, but other policies like new programs for dual eligibles like DSNPs, and sorry for the jargon there, but they are going to be requiring plans to put forth information about their dementia screening rates in their populations. We know that the Medical Board of California is requiring providers who see older adults to get training in either dementia or geriatrics, at least 10 hours out of our 50-hour requirement. I'll just put out there that that's all available at Dementia Care Aware for free. If you go through our trainings, that would count. We also know that therapeutics, and I mentioned it briefly, and I should have said therapeutics and diagnostics are really changing the way people think about Alzheimer's disease specifically. And what I would say is we're always going to need a general dementia approach. Lots of people don't have Alzheimer's, but have dementia syndrome. So we want to be comprehensive in how we think about our care. And then finally, the guide program, I know in our area, is really motivating people to think about, how can I detect dementia so I have more to do. I can really connect people to this wonderful care navigation program. So in many, many places, that's going to open up starting next July. In some places, there's already some guide programs, but they should all be operational by July 2025. So detecting dementia is of real benefit in that sense as well. So we know we live in a state rich with resources, in part thanks to the incredible work of West Health already, transforming the care for older adults. We're not on an easy road, and it's a little curvy, it's a little steep, but it's easier together. So we really want to partner, and we're absolutely one of our new horizons would really be to partner with and work with clinics to implement a dementia care pathway. So thank you. That concludes any sort of slide presentation. But happy Thanksgiving, everyone. You joined us on a holiday week. That is dually, triply wonderful. So I will open the lines to see if we have any questions.
The one thing, Anna, if you want to shed some light on, when we think about advanced care planning, I think that's really important. But even outside of advanced care planning, understanding the patient's goals and goals of care, and how do we incorporate that, because that can really have a huge impact on the journey that that patient will go down.
Yeah, I'm truly, I've been trained by giants in the field, so I hope I represent them well. But you know, the prepareforyourcare.org website, I think is one really good one that helps explain kind of why we're doing advanced care planning. There's also clarity. The advanced care planning, really we talk about, and that's kind of why we upfront it with screening, which is to say that you can do it in bits. You can triage it much like you triage the actual dementia workup. So first of all, making sure you know if there's anybody in their life is actually a huge piece. And then asking, and we usually document in those moments, have you designated this person with any official role, like as a surrogate decision maker? So starting with the surrogate decision maker piece, because that's something we all need. We could all at any point, unfortunately, and I knock on wood here, we could be incapacitated, unfortunately. And so really planning for incapacity is sort of step one. Then it's about, once we've established that, it's sort of like the other pieces of the screening, we can circle back and start to support them on formalizing that. And the two pieces I usually talk to people about are planning formally for designating someone as a healthcare decision maker. And then the other is a financial decision maker, which is just the way the law works. We need to designate both. The reason it's really, really important in dementia is because we know people may get to a point that before we've done that work, that they can't participate enough in that process, and then they never get it done. They're sort of in a legal limbo. The other is, even though we may not be so great at it in terms of really walking people down the path of all the advanced care planning pieces, and we need lawyers and we need additional services to support them, a really, really big message you send is we all have to do this. This is really, really important for planning for the future. And you know, you may have a condition that impairs your decision making in the future, and we just want to be prepared for that. And that starts to open up for people thinking about, well, how do I want my care to be? How do I want my life to be living with this condition? And that is one of the hardest things about diagnosing later, is we've really robbed them of that time to express those opinions and to think about those views. So what we do in our health record is we triage it. We mostly focus on documenting surrogates, then focus on formalizing that. And then as a condition worsens or as other context comes in, we also work with them on refining their wishes around their specific healthcare. Like, I don't want to be hospitalized anymore, or I don't want certain interventions anymore. I don't want dialysis if it comes to that. That ends up being more context specific, whereas the surrogate and planning stuff is really, really key. We can do that in tiny, tiny bits all along, like we're doing the dementia diagnosis and screening. Okay, so that was way too long an answer, but thank you for that question, because we're really passionate about it. We have so many resources. We have a whole medical legal practice website on our page on our website that I really want people to know about. So someone has asked really briefly, what would a partnership look like? And really it's about having a conversation, us figuring out how we can support you and showing you how you would implement an early detection and dementia care pathway with whatever healthcare team resources you have. And the real goal here is real primary care, real world setting, and how are we going to do this? And we can always kind of connect to other resources that we know about if, you know, the level of coaching, if you will, is not something we have enough of. But, you know, helping people connect to things like getting age-friendly health systems certified if needed, and how to work with the EHR, whichever one they have, and get sort of these pathway pieces embedded. So that's really what we're talking about. And if possible, we'd love to think about, supporting training and additional capacity building, but it's really about talking about the implementation resources and supporting you through that. I know we have 1 minute. So somebody says, how do you differentiate normal aging or menopause versus more significant cognitive impairment? And it's really about trajectory and severity. So everybody has changes in cognition. That's to be expected. And some of that are dips around menopause or other major life issues. But it's about severity, like how severely is it affecting your life? Does it fall into a category that really is not within the range of normal expected for age? And that may be something that, if you can't quite figure it out, if the person's pretty complicated, an additional specialist at some point can help. But it's really like, is it beyond compensatory strategies like writing things down or putting things on a calendar or getting reminders? Somebody had a wonderful suggestion from a wonderful colleague about having a webinar on over-the-counter supplements that people take for memory loss. And it's a great question because twice this week already, I had people ask about certain OTC supplements. So I can tell the marketing is very effective. So thank you. We will definitely think about that and plan that. A colleague from New Orleans is reaching out and would love to work together. And that is another big message. We're very California-centric, California dreaming, but we are ready to expand. So please reach out and please send us your email to dca@ucsf.edu and we'll absolutely schedule a meeting. Honored and privileged to be with you on this holiday week. Zia, thank you so much. It's beyond joyful to work with you. I'm very grateful for this partnership. And I just want to say happy Thanksgiving to everyone.
Happy Thanksgiving to everyone. Thank you.
Thank you.